Now, I will give you the little time that we have. I will show you how changes take place and how the number of standards and objective elements they keep changing from one edition to another edition. There are 10 chapters in NABH standard. The chapters are like this: access assessment and continuity of care, that deals about the registration part, admissions, transfers, and up to discharge. Then actual care of the patient, treatment given to the patient is covered in the care of patients chapter, that deals with all the specialities that are there in the hospital. They are covered. One each standard is dedicated to one specialty. Like pediatrics, one standard is there. Gynecology, there is one standard. For all surgical services, one standard is there. For anesthesia, there is a standard. For emergency, there is casualty, you have a standard. Like that, you have about 20 standards. Then management of medication, it contains of two things. Management of medication covers the pharmacy part in the hospital and also the administration part, medication administration part. That is covered in the, that is actually takes place in the ward by the nursing staff. Then patient rights and education, hospital infection control. In patient rights and education, as a patient, what are his rights and what are his responsibilities also? If giving a consent for a certain procedure is his right, paying the bill on time is also his responsibility. So there is a charter of patient rights. Government has, in fact, government of India has released a list of patient rights and responsibilities also. They should be displayed in all the hospitals, and they will have to, we'll have to educate them about their rights and responsibilities, and patients also should be complying with that and modulate their behavior according to that. The hospital infection control deals with what are the places where the infections are likely to take place and what preventive measures one has to take to avoid the infections. Then this is the chapter on continuous quality improvement. Now the name of the continuous quality improvement chapter has been changed. Till the fourth edition, it was continuous quality improvement. Now in the fifth edition, what they have done is they call it patient safety and quality. They call it PSQ because they wanted to emphasize safety. The if you take any quality standard, two things that they are bothered about is the quality of the service and safety of the person who is availing that service. We should not be causing more harm than the disease causes to the patient by providing our service. Then the responsibility of management. What is the management expected to do? What are the responsibilities of the management? Like they should have all licenses for doing these business operations, whatever licenses that are applicable to a healthcare organization. They have to register their organization according to the Clinical Establishment Act. They should have a license for their pharmacy. There should be a license for the ultrasonography. They call it PCPNDT Act. If the hospital is performing MTP, they should have an MTP license. And if they have imaging devices, they have to register all those equipment with AERB, Atomic Energy Regulatory Board. So all these things, that is the responsibility of the management to obtain all the licenses, whichever is applicable, and abide by the law and continue the business operations as per law. Then facility management and safety. It there are two issues when you talk about the patient safety. One is clinical safety. We should not be causing any harm to the patient. That is clinical safety, and there should not be any harm other than the treatment part. There should not be a calamity of some electrical causing an electrical burn during the treatment or some fire taking place. These things are general calamities, so general safety is also the responsibility of the organization. Then HRM is human resource management that entirely deals with your recruitment and all. But when we talk about the hospitals, one thing you have to remember is the credentialing and privileging. That is part of the human resource department. You have to, the doctors and nurses and other paramedical technicians whom the hospital is hiring, they should be qualified and they should be registered with a respective organization. If an MBBS is there, you should take registration from the MCI, Medical Council of India. If nurses are there, they should be registered with the Nursing Council. They should have a GNM or a BSc. ANMs are not permitted to be taken as a part of the accredited organization. And the paramedical staff also, they should have their registration. If the X-ray technicians, the OT technician, the laboratory technician, they should all be registered. Pharmacists, they have a pharmacy council also, they should be registered with the pharmacy council. So you have to take such qualified and registered people only. And what is privileging is, according to the qualification and experience of these people, you will have to give them their job responsibilities. Suppose you have taken a urologist who has specialized, it is a super specialty, he is specialized in tackling with the problems of the genital urinary system. Now, if you give him, you have to give him the privileges which are within his specialty. You cannot give him a privilege to operate with a gastrointestinal problem because he has become a super specialist, his system is different. Similarly, a cardiologist, he should be dealing with the cardiovascular system. He should not be, he can be given privileges within that system only. He cannot be given privileges to handle any other case pertaining to, say, neurology. So that is privileging. Similarly, for sisters also, if they have had the skills of working in the operation theatre, they should be posted in the operation theatre. If they are trained with handling the NICU, that is neonatal intensive care unit, or babies in the pediatric intensive care unit, they should be posted in the pediatric ward or the neonatal ward. They should not be posted in the adult ward. Then there is privileging for these allied health professionals also, that is the laboratory technician, or if you take the ophthalmology OPD, you have optometrist. So according to his qualification, they are also registered. According to his registration and skill set, you give him the privileges as to what job responsibility he should be having as far as providing care to the patient. So this is an important part of the human resource management chapter. Like this may not be there in other HR departments in other sectors. So this is specific to the healthcare sector. Then the information management system, it has two components. Information management system is how you are capturing the information. So that may be your hardware and software related to information technology. The rest of the IMS chapter is about what should be there as contents in a patient file, that is medical records. All the medical records, the laboratory test reports, the X-ray, CT, MRI, the imaging test reports, the case sheet written at the time of admission, the case sheet written with the progress notes subsequently, all these things till at the time of discharge, a discharge summary is prepared. Till a discharge summary is prepared, entire thing becomes a medical record. So, dealing with what contents are there in the medical record, what are the compliances that all those who are making an entry in the medical record they should be doing, all these things are dealt with in this IMS chapter. You take JCI also, JCI will be similar to it. Maybe the nomenclature is slightly different because the chapters are the same. No, this is the continuous improvement which I am referring to. If you have a look at the CQA NABH standards, uh, it started in 2006 till 2020. There is no difference in the chapters because, as I told you, the same 10 chapters are there. But if you look at the content of the chapter, you find the standards and OE is objective element. Standards, they kept on the first it was 100, then it became 102, then it went to 105, and it got again reduced to 100 in the fifth edition. But if you look at the objective elements, initially they were 505, it went to 514, then it became 636, then it became 683, and now it is 651. So there is a variation. But when I say it is continuously increasing, in JCI, both the standards and the objective elements, quantity wise, they kept on increasing. But here, we are not overloaded with that, but there has been some shuffling. uh, some elements from one chapter have been coupled in the other chapters, and some of the elements have, because they found it has no relevance to the process, they have been deleted. Such changes have taken place. But where it started as 505, now it has come to 651. Maybe it will increase next time. It happened, same thing happened in ISO standard also. Now, if you look at it, these are the changes in different chapters. What I showed in red is the latest, that is the fifth edition, and what I showed in black is the fourth edition. So, chapter wise, I have given you how many standards are there and how many objective elements are there. But what you are seeing after that, prior to the fifth edition, there was nothing like a core element, there was nothing like a achievement element, there was nothing like an excellence element. This is the change now. They brought a new change and they have identified certain objective elements as the core objective elements, some of them as the achievement objective elements, and others as the excellence objective elements. When you go to the next slide, you will understand why they have kept it like that. So this is about the first 5 chapters, and these are the next 5 chapters. If you see now, PSQ is there in the fifth edition. Earlier, what I showed was the continuous quality improvement chapter that has become the patient safety and quality now. Now, here also you have the core achievement. Ultimately, you have about 102 core elements, the 60 achievement elements, and 30 excellence elements. Apart from that, all the rest of the elements, they are called the commitment elements. Now, when a hospital goes for an accreditation, they said they have classified as to how many, what are the compliances required. See, initially the compliance may be only required for core elements. When after 1.5 years you go for the subsequent assessment, although you are given a period of 4 years, at 2 years there will be another assessment. They call it a surveillance assessment. At the end of 4 years, it will be a re-accreditation assessment. RA, SA and RA they call it. So when you reach the re-accreditation level, more elements will come. That is how you are scaling up actually. Your performance of your process is getting scaled up. Now, some broad changes that has taken place from fourth edition to fifth edition of NABH is they have minimized the objective element that can be scored only as all or none. Earlier, uh, there was something like scoring system. I will be showing you the example of how scoring takes place. In scoring system, they had only three levels given. If there is no compliance to the requirement mentioned in the objective element, against that objective element, the score given is 0. A license is supposed to be there. If the license is not there, so it is given a 0. If the license is there, it is given a 10. In other objective elements, if there is a partial compliance, then it is given a score of 5. This is how the scoring was done earlier, 0, 5, 10. Then the feedback went from the organizations and the SSRs also that probably it is not practical. For everything, you can't say it is 10 only and it is 0 only, and if it is neither 10 and not 0, you put it as 5. They said there has to be some score between 0 and 5 and some score between 5 and 10 also. It can't be your performance is absolutely 0. Unless if that example of license is given, okay, license is there, should be there, it is not there, then it is a 0. But in any other thing, if a document has 10 entries, like you have a consent form and some 5 parameters are to be noted in the consent form, 3 parameters are noted, 2 parameters are not noted, you can't give a 0, you can't give a 10, so you will give a 5. But maybe 5 is also not correct, it may be 6, 3 out of 5 are there. So when this feedback went, they implemented it now, and that is why the system changed it. So that is how it has minimized that. Then a phrase is used, written guidance is used to guide implementation of the standards. Earlier they used to say there should be a documented procedure. Now instead of saying a documented procedure, now they are saying a written guidance to guide the implementation of the standard. That means you have to write down a procedure only, but the word written guidance is it, and changes are there in scoring. The other things are the earlier the focus was more on documentation, and now the focus has shifted to implementation. See, you may be writing down a procedure as to how you should be carrying out a particular action, but in actual practice, when it happens, that is when it is implemented, only the results will come. So now the focus is on implementation. You might have written anything, but have you implemented it or not? Like I'll give you an example. In the laboratory, whenever you get a critical result, that means there are normal values for your blood sugar, normal values for any other test, blood creatinine, sodium, potassium. If it is less than the lower level and above the upper level, it is out of range. So we call it a critical alert. If it is out of range and if it is a critical patient in ICU, the lab people, instead of writing down the lab report and keeping it there for the nurse to come and collect it, they should immediately intimate it to the department concerned, or the sister of the concerned with of the patient or the duty medical officer, about the abnormal lab report. So that you have written it in the procedure, but when you go for the assessment and the inspection, you ask them to show which are the results which are abnormal and have you intimated it to the department. Then there is no record showing that they have intimated. If there is no record, we feel that it is not implemented. So now the focus is on implementation. Then they have streamlined the interpretation. It is not simply mentioning a objective element or writing down a standard. They give a description of what they mean by that objective element and how it should be, what the SSR will be expecting while you are implementing it. They have also given a direction that if the words shall and should, will and would are there in the written statement or the sentence, then you have to take it that it is mandatory. But if the words can and could are used, it is not mandatory, but it is good if you do it. So if a particular sentence has, it could be applied or it can be done, you cannot give a non-compliance against that. You cannot say they have not implemented it, because it is only for improvement they have used that it could be this. you can do this. So they have used this language, and they have mentioned in the fifth edition that wherever you find these words, you go according to that. If you find a shall and should, it is a mandatory requirement. If there is a can and could, probably it is not mandatory, but it will be good if you implement. Now, this is the breakup. The earlier told you, no, there are different categories of objective elements like the core elements, commitment elements, achievement elements, and excellence elements. The figure breakdown is given there. There are 102 in core category, 459 in the commitment category, 60 in the achievement category, 30 in the excellence category. Now, in this is one example of an achievement category. That means it is not expected in the first assessment only achievement. The COP is care of patient chapter. In care of patient, you have standard 8, objective element is 8G. So in that objective element, it says post-transfusion forms are collected, reactions, if any, are identified and are analyzed for kappa. Kappa is corrective action and preventive action. Similarly, in COP 8H, they said organizations shall implement a quality assurance program. How are you ensuring the quality in this one? Because COP8, it all deals with blood transfusion, blood and blood products, blood transfusion and all that. So this is an example of an achievement category element. Now this is a excellence category element. Here I have taken the example of care of patients in standard 6. The organization implements acuity based staffing for better patient outcomes. Acuity based staffing is depending on the seriousness of the case of a particular patient, you will have to allot a suitable nurse to take care of that patient. That is acuity based staffing. Earlier I was telling you, the sisters who are trained in the pediatric cases, if you post them in the adult cases, they may not be all that good. Similarly, sisters who have been trained to nurse the adult category patients, if they are posted in the pediatric ward, they may be finding it difficult. In fact, when you go to the hospital, if you observe as administrators, if you are to collect the blood sample from a child, the pediatric trained nurse collects it much better than a nurse who is trained in the adult category, because it is only a skill, and that skill is because day in and day out the pediatric trained sister will be handling the babies only and collecting their samples. They will be very good in doing it. Not that the other sisters cannot do it, but better quality, that is why he says for better patient outcomes, acuity based staffing should be taking place. This is a new element that they have kept. Now, patient outcomes are linked to acuity based staffing of nursing personnel in terms of numbers and competence. Numbers also. Now, why we say numbers is, suppose you in the ICU setting, the nursing council says you can give one nurse to two patients in an intensive care unit. In the wards, it can be one nurse for 6 patients or 5 patients. Suppose the patient in the intensive care unit is put on a ventilator, then the staffing should be one nurse for one patient. Or if there is a requirement, any requirement which the surgeon or the consultant for that particular patient feels, you may have to give two nurses also to handle one case. So the numbers of the staff to be allotted also depends for better outcome, better patient outcome. So now this emphasis on better patient outcome was not there earlier. This is a new change, and that is why they have kept it as an element, not for hospitals which are going for an initial first time accreditation. This excellence element they need not comply. They need, it may be a zero also. But it is not a bad mark if they have not complied. But by the time they go for the re-accreditation, the excellence should be completed. There should not be a zero for this element. So examples of outcomes, better outcomes include incidence of pressure ulcers. Patients who are bedridden for a long time, there will be pressure ulcers. So developing a pressure ulcer is not a better outcome. Fall of the patient, medication administration errors, and patients who are put on ventilator may develop a respiratory infection, pneumonia. All these outcomes are not good outcomes. So for that, there should be an acuity basis staffing. Now comes the core elements. Of course, standards of the organization should have in place. Transfusion of blood and blood products is done in a safe manner. It is a core element only. But why they said core element is, initially when one is going for a accreditation, they must comply with these 102 core elements. There is no exception here. One who is starting their quality journey and quality accreditation on the 5th edition of NABH standards, they must comply with all the core elements. Now we come to the differences in scoring. As I told you earlier the scoring was 0, 5 and 10. Now the scoring is 1 to 5. So this is how it is given. If it is a 0, 1 score, they say the first two I am skipping. The last description is, suppose you have taken few samples, you have gone to the laboratory and you have taken few auditing samples. Out of the 10 auditing samples that you have taken, not even 20% are compliant, less than 20%. It shows less than 20%. Then your score is 0, 1. Score is 1. Similarly, if you take the samples in another area and the compliance is 21 to 40, say 3 of the 10 samples are compliant, 4 of the 10 samples are compliant, then you will give a score of 2. 41 to 60, you give a score of 3. 61 to 80, you give a score of 4. Of course, 81 to 100, you give a score of 5. There will be no NC. But in 0, the score of 2, score of 3 and score of 4, in score of 2 and 3, NC is definitely there, non-compliance is there. But in a score of 4, NC may be there, NC may not be there. So that with the experience of the assessor, that assessment will be done. That scoring will be done. Now, how does a organization get a score? Now, here also, my theme that there should be continuous quality improvement. When NABH 4th edition standards were implemented in the hospitals, the compliance required for declaring an organization having passed the accreditation test and giving the accreditation certificate was only 70%. But now they have raised the bar to 80%. They said a overall compliance rate of at least 80% should be there. In the core elements, the score of less than 4 should not be there. No individual standard should have more than one objective element scored as 2 or less. If you take a standard, suppose in that standard 4 objective elements are there. More than one objective element score of 2 or less should not be there. If there is a score of 2 for one element, it is okay. If you take the standard, average score should be again, it should not be less than 4. That is 80% only. 4 out of 5 you are giving. If you take a chapter also, average score should be 4. Every objective element with a score of 3 or less should have an action plan, accepted action plan with timelines. The hospital has to give in writing as to how they are going to improve that particular requirement. Every objective element is a requirement. That particular requirement where they have got a score of 3 or less, they have to give an action plan. How much time they are going to take for improving it and how they are going to improve it. They have to write down and give it. And when next assessment, when the SR comes, he will review it, and the score should have become 3 or more than 3. Now, this is SAI surveillance assessment. In surveillance assessment, of course, more achievement level objective elements, which we have earlier discussed, achievement level objective elements will be added. That is about 60 elements are there. These are not there in the first accreditation process. And the improvement in score of objective element from previous assessment, which was scored as 2 or less, there should be an improvement. See, suppose out of the 651, the organization has had about 25 objective elements, the score was 2 or less. For all those objective elements, the score should now have gone to 2 to 3. Now, don't ask me what happens for others. If they drop down from 3 to 2, then you have to ask an explanation why it has dropped. Or the organization itself should have worked out by then as to what they should do about it. This one is reaccreditation, and here 30 more elements will be added, and all 80% should be there. Commitment, achievement, excellence, all scores should be 80%. For when you go for reaccreditation, now if this achievement, this score is not achieved, your accreditation will get deferred. The organization will not be accredited, and they will lose all the benefits that there are certain benefits which are given to the healthcare organizations which are accredited. They will be losing all those benefits. Now, if you total the score, depending on the number of elements that are there, this is what it is. In a final accreditation, that is first time, you have to get a score of 2244 out of 2805. In next one, they should get 2484. Next one, they should get 2604. This is a mathematical calculation. Number of elements multiplied by the score. You should get a minimum of 4 score for overall. So you multiply 4 into that many elements.